change your clinical practice. Let's care for our patients, communities, families better and better. And importantly, let us remain health workers who are competent and also share with other colleagues. Our evening webinars are open access. However, for you to be eligible for any CPDs or administrative support, discounts, and many other benefits, we want to encourage you to visit our website, look at our membership offering, and if we're able to meet some of your expectations, we encourage you to join in and be part of the community. On your right-hand side there, you can see that thus far we have issued over 40,000 CPD credentials to health workers, and we wouldn't want to miss you. Like I've said, visit our website. There is a lot of benefits for supporting this platform, and we hope that we will welcome you very soon. Just at a high level to say that we are also offering diploma preparatory programs. There's one for those who are interested to write the HIV college exam, the HIV management college exam in July. But also if you would like to prepare for the next ones, which will be in February next year, or maybe you just want to be a very good HIV clinician, do join us. The same applies for obstetrics. Do join us. I think yesterday we were looking at hypertensive disorders in pregnancy, and it was quite an informative session. And yes, in internal medicine, it's the same program, and we are now actually going to be looking at pulmonology this particular week. So today we have pulmonology 1, and then on Friday we have pulmonology 2. So if you are interested to write or just to become a very good physician, just join us and be better and better. Before I introduce today's session, just to say that we have master classes. So master classes are the events we host over a Saturday from the morning to afternoon. And we kind of like choose a very important topic and we deal with it end to end, from anatomy to physiology to treatment and diagnostic criteria and how to manage your patients better. So if you're interested to learn more and master how to manage erectile dysfunction, do visit our website. And this particular masterclass is scheduled for the 1st of June. And lastly, yes, the chest X-ray interpretation masterclass is back. This is going to be our second intake this year. So the next one is on the 15th of June. So yeah, visit our website and learn more. But yeah, let me not bore you more with all these programs, but to focus on today's program, which I think is very, very, very important, because most of us men, at some point, we are going to experience a shortage of certain hormones. And therefore, you know, we might struggle with certain things and stuff. So I'm not a specialist in this area, but just to really appreciate the collaboration and partnership with Dr. Sadwani, Sanjay, who is a specialist urologist, and he also has a special interest in minimal invasive surgery. He also holds a position of a consultant urologist at Grace Hospital in Pietermaritzburg, and is also a lecturer in the Division of Urology associated with the University of KZN. Very, very, very important to note his credentials, but also that he's as human as me and you, because he just enjoys marathon running and mountain climbing. The only thing missing, Sanjay, is for you to take me with you on your next mountain climbing.
Exactly. I can
Welcome,
promise you,
Sanjay.
if we go for that run, our testosterone levels will definitely go up.
Yeah, that's the plan.
Thank you so much.
Thank
Thank you for the
you.
introduction. Wonderful. Okay, great. I'm just checking. Can you see my presentation and screen quite well?
Yes, it's now on full screen. Thank you. All is clear.
Thank you so much. Okay, so good evening, everyone. Thank you so much, Nisego, for the introduction and for this opportunity to share this topic. My name is Dr. Sanjay Sadhwani. I am a specialist urologist, And today I'm going to be speaking to you about a topic that's quite important into our daily practice. Male hypogonadism or testosterone deficiency syndrome affects 30 to 50% of men with obesity or diabetes. Now, we know in South Africa, our population don't just present with one or the other. I mean, just looking at the patients that come to clinic, you have a patient who's diabetic, hypertensive, with thyroid issues, who also is compounded with HIV disease. So our statistics are a lot higher, and a lot of these patients are undiagnosed, and some will get lost in the system. So hopefully this presentation can bring some light, and we can make an impact in some of these lives of these patients and give them a better quality of life. I think that's the goal for all of us at the end of the day. Okay. Wonderful. So what is male hypogonadism? So basically, it's a clinical syndrome which comprises of symptoms with or without signs, with biochemical evidence of testosterone deficiency. So this can either be due to decreased testosterone production or function, and it may or may not involve impaired sperm production. So it's important to remember that this disease doesn't just affect the man in a relationship, it also affects a woman. Remember, hypogonadism is not only have its role to play in sexual dysfunction, but also in mood, energy levels. A lot of these men are breadwinners in the family, so these symptoms are significant to pick up because we can actually make a difference in their day-to-day function. So let's go back to mid school, our normal physiology of testosterone production. I know everyone has seen this picture at some point, and I do remember the first time I saw it was quite daunting. I like this picture because it's fairly simplified. So let's go back up to the brain. Hypothalamus produces gonadotrophin releasing hormone, which then goes to your anterior pituitary gland. And the anterior pituitary secretes two hormones, which is your FSH and your LH. Both go down to your testicle and tell your testicle, hey, listen, the LH tells the testicle to start the Leydig cells to produce testosterone, whilst the FSH tells the testes to produce the Sertoli cells to produce spermatozoa. So that's normal physiology. However, in hypogonadism, one of two problems can prevail. You may have primary hypogonadism, which means that the brain is fine. It's producing, the hypothalamus is sending out its GnRH, telling the pituitary, hey, produce some FSH-LH. That works perfectly. It produces the FSH-LH. It gets down to the testicle, and the testicle says, I'm sorry, I can't do this. I can't produce the testosterone. So that's primary hypogonadism, or as they would say, hypergonadotrophic hypogonadism. While secondary hypogonadism is where there's a problem with the hypothalamus or the pituitary in the production of GnRH, FSH, LH. But here you have a testicle that's perfectly functional and able to produce testosterone. So just to start off the day, it's nice to make it a bit more interactive. I'd like everyone who's available to just maybe answer the question on the chat. So which of these options can lower your testosterone levels? Infrequent sexual activity, smoking, alcohol, smoking and alcohol, or none of the above? And let's just have a look at the chat and see what everyone thinks. So Miss Rochelle Adams says D. Pusisiwe and Asanda say C and D respectively. A lot of Ds. I hope that's not a joke for hypogonadism. A lot of Ds. Overwhelming D. There's one A. I'm quite happy. So let's go back to Timbiso and Kobese said A. So, sorry. I got excited there. Sure. With regards to, okay, great. So look, the consensus here is pretty much on D, hey? Which is good. Thank you everyone for the feedback and for participating. So yeah, I think the right answer is actually C. Alcohol significantly lowers testosterone levels, and the way it does that, it acts on the liver and then promotes estrogen metabolism and inevitably drops your testosterone levels. Smoking, surprisingly, and I found this very, very interesting, smoking actually increases your testosterone level. And the way it does that is that nicotine has a metabolite that inhibits androgen breakdown. So that inhibits testosterone breakdown. So normally testosterone is produced in your body and then starts to degrade into its constituents. But the metabolite in nicotine inhibits that process, so you have a higher circulating testosterone. The reason I put that picture in there, which I thought was quite interesting, is I don't know if you remember back in the days where they would have these movies where there would inevitably obviously be a sex scene, and during the sex scene, either before or after, they'd light a cigarette and lie in bed for a while. Testosterone is very important for libido, not just in a man, but also in a woman. That's where the association of smoking and sexual activity came about. And I found that remarkably interesting when I saw it. Not to say that smoking is one of the treatment options for hypogonadism. Inevitably, it does lead to hypogonadism in future because of this association with peripheral vascular disease and other metabolic disorders. But just something I found very, very interesting. I'm surprised. I know one person answered A, infrequent sexual activity. I hope that was a male person because that's one way to tell your wife to increase your testosterone. So but we can always argue that point. Wonderful. Okay, so primary hypogonadism. These are, look, I know this is an overwhelming slide. I put it out there just so you can see the variety of potential causes for hypogonadism. I don't want you to try and remember this or learn this. It's just there to highlight the vast realm that exists in this topic. Genetically, the most common cause would be Klinefelter syndrome, right up here. That's when a male patient has an extra chromosome, an extra X chromosome. These patients often present, believe it or not, undiagnosed. Most of them have no symptoms or signs, and often gets diagnosed later in life when they find out that they're unable to bear children, and then they are infertile. Other causes for primary hypogonadism are testicular torsion. That's something we see very regularly in urology. I saw a patient with mumps orchitis last week. Patient came in with gynecomastia. Semen analysis showed azoospermia, absolutely no sperm whatsoever. And it's a young guy, 21-year-old, and he's quite distraught about it. But just to highlight that these things do actually happen in clinical practice and not just for the books. Secondary hypogonadism. So this is your hypogonadotropic hypogonadism. Here again, huge number of causes. I won't go through all of them, but it's just to highlight the vast realm. Androgen resistance is another cause of hypogonadism, something that we don't come across every day. Often these patients would be referred to a specialist, but aromatase deficiency or 5-alpha reductase type 2 deficiency can manifest in patients having, so these patients have normal testosterone, it's just that they're not able, or the body's resistant to it, so they don't actually get to have an effect. So hypogonadism actually is a misnomer. The term has been adjusted to a multitude of different terms. So ADAM was one of them, which was the aging decline of testosterone in men, whilst the others like late onset hypogonadism is what we're going to focus on today, where as the man gets older, they tend to have testosterone deficiency. Andropause is a nice nifty one, just to equate to menopause. But the most correct term is testosterone deficiency syndrome. So this is what testosterone does from our inception. So from the time you are conceived, from about 8 weeks to about 14 weeks, you start to have a spike in your testosterone intrauterine. The reason for that is because that helps differentiate the genitalia from whether it's going to be male or female. So at 8 weeks, it starts to rise. It starts to peak around 11 and 12 weeks. And obviously, we know that we can assign gender or not assign gender. We can discover the gender of the child on ultrasound by from 14 weeks onwards. So the testosterone itself is not responsible for that, but its conversion to DHT is responsible for external genitalia involvement, whilst testosterone is responsible for internal genitalia involvement. In the neonatal period, they have another spike of testosterone, and that fairly comes down for a long time until we start reaching puberty. And as we get up to puberty, we reach our peak of testosterone that we will have in life. And thereafter, at around 30 to 40s is when this slope happens. And this slope goes significantly lower. And as I said, it can start to affect about 50% of the population. So here is the rate of decline of testosterone by age. As you can see, that youthful basketball player there at 25 still manages a handsome pose at 35. Yeah, something happened at 40, 45, it just, you don't want to stand anymore, you want to just sit. But yeah, this is what happens as age progresses. So yeah, statistics are variable. They document about up to 20% of elder men. From the age of 40, testosterone starts to drop by 1 or 2%. annually, and this incidence increases with age. The reason it also increases with age is that nowadays we're having a higher incidence of people living a lot longer. So men are living a greater lifespan. Therefore, we are coming across these kind of pathologies and able to treat it and make a difference to it as well. So why does testosterone drop with age, right? Why can't everything just stay perfect all the time? I mean, so as with anything in life, everything has a lifespan. So does our hypothalamus. It starts to age. Our Leydig cells start, going on strike and saying they're not going to be sensitized to luteinizing hormone anymore. We have a decrease in number of Leydig cells as we get older. And also, as you get older, you have something called your SHBG, which is your sex hormone binding globulin. That starts to increase. So this is your non-bioavailable testosterone. I'll explain it nicely on the next slide. So testosterone has three components. So you take a blood sample, in your blood, you have testosterone. That comes in three different forms. Either free testosterone, albumin-bound testosterone, or serum hormone, a sex hormone binding globulin-bound testosterone. So the way I want you to remember this is that this is the good stuff. The albumin and the free testosterone, that's what is bioavailable. So that's actually contributing towards your health. The SHBG-bound testosterone is pretty much occupying space. So that's your non-bioavailable testosterone. Now, as you get older, this proportion, and along with some comorbidities, increases this proportion of testosterone. Why is this important? Why am I telling you this? So your total testosterone is your free testosterone plus your albumin testosterone plus your SHBG testosterone. Now, you can have a patient with a normal testosterone level, but he comes to you and says, "Doctor, I feel weak all the time. I'm having some trouble in the bedroom. I feel very moody. I get irritable. I feel hot all the time." But you check his testosterone and think it's perfectly normal. But he's 75. He's got a high proportion of SHBG that's compensating and making the total testosterone appear normal. But when you actually measure his free testosterone, you will see that his free testosterone or his bioavailable testosterone is actually low. That is wonderful. Like I love the fact that that makes sense to me, and that it's nice when you can figure out someone's pathology on a different basis like this. So what causes SHBG levels to increase? So we spoke about aging, and we spoke about how that affects testosterone. Liver cirrhosis can also affect it. Hyperthyroidism, there are a few individuals who are hyperthyroid who are electively put onto testosterone therapy because they have certain features of hypogonadism. And I'm talking about 23, 25-year-olds on this therapy. Anticonvulsants, patients on estrogen, and boom, a very big one that we need to acknowledge in our population is HIV. So just think about it. As I said in the beginning, our patients are diabetic, hypertensive, high cholesterol, and a large proportion of them are HIV positive, which puts into realms already 4 risk factors that we see in our clinics on a day-to-day basis for hypogonadism or testosterone deficiency. Okay, other comorbidities associated with the late onset hypogonadism: obesity, type 2 diabetes, metabolic syndrome, and of course, COVID-19. My last presentation in STIs, COVID-19 made an appearance, and again, it's making an appearance. I have a feeling the next one will make an appearance as well. But let's just talk about obesity. So obesity makes sense. Remember, the process of aromatization happens in adipose tissue, in fat. So the more fat you have, the more aromatization you have, the more estrogen gets produced. That will feed back to your hypothalamic pituitary gonadal axis, block off that testosterone. There's trials to show that patients who are treated with testosterone therapy in hypogonadism or who are also diabetic can actually end up in remission of type 2 diabetes. Basically, you can reverse the insulin resistance by treating these patients with testosterone therapy. However, obviously, it should never be given as monotherapy. It needs to be given as basically weight loss and diet programs and those kind of things. With regards to COVID, there's evidence to show that patients with COVID-19 had significantly lower testosterone levels. And those patients with lower testosterone levels also had a higher risk of having ICU admissions and also of potential death. So, there was a lot of research that went on to this because they even found COVID to be present in testicular tissue. So I think that's where the suspicion came of the damage to the Leydig cells and the ability to produce testosterone. So they tried supplementing these patients with testosterone therapy to see if it made a difference. Look, the results are very conflicting. Nothing set in stone, and there's no conclusion as to if there is any benefit in giving testosterone therapy to these patients. Okay, let's talk about more evidence. Look, we're working in a world of evidence-based medicine, so everything we do needs to be backed by evidence. So this was a study by Kapoor et al., basically showing the association of hypogonadism in patients with type 2 diabetes. And basically what it shows is that the percentage of men with low testosterone were higher in the diabetic population than the non-diabetic population, which, as we spoke about, comorbidities and assessing for these comorbidities are very important in this population. With regards to COVID-19 and testosterone and mortality rates, as you get older, mortality rates start to increase as your testosterone levels drop. Again, very, very important. This is the Kaplan-Meier curve. So as you read more and more research articles, you'll find that these curves are quite prevalent, and it's basically a survival curve to delineate the survival of patients with, in this particular case, with normal testosterone compared to low testosterone. You can see the survival for patients with low testosterone is significantly lower than patients with normal testosterone. And this was specifically in a group of patients with cardiac failure. And then we had another paper by Hackett et al. And what I liked about this paper was that they actually gave these patients testosterone to see and compared mortality in these patients as opposed to patients who had hypogonadism, but who were not treated. And if you can see a huge significant difference, I mean, you got 19.7% mortality in patients with hypogonadism, which were untreated. Patients who were treated only had a mortality of 3.6%, even better than patients who had normal testosterone. Now, I'm in no way meriting giving testosterone to someone whose testosterone levels are normal or asymptomatic, but it's just interesting to see that testosterone therapy has a significant impact in mortality. So let's move on to a clinical approach to testosterone deficiency syndrome. So in order to diagnose a patient with late onset hypogonadism, you need to have a certain signs and symptoms in combination. So there needs to be signs and symptoms of hypogonadism. There needs to be biochemical evidence of low early morning testosterone. This needs to be done on two or more occasions to exclude an error. And you need to use a reliable assay, and this needs to be done in fasting conditions. We'll speak more about the details of this in the coming slides. So this is the typical gentleman that will walk into your room with hypogonadism. I know what you're all thinking. Sanjay, you got a photo of my grandfather on your screen. Why? That's a bit weird. But that's generally what they look like. We see these patients on a day-to-day basis. Hell, some of us might even look like this, and there's no judgment there. We work hard lives. We're on call. So if you want to eat the Simba packet of chips, please do. But just keep in mind, when these patients come in, they specifically with the sexual dysfunction, remember, men, as Dr. Lusarko was saying earlier, men don't like talking about their health. Now, that's health, that's general health. When you add sexual health into it, that's even harder to talk about. Excuse the use of the word harder, but it's very difficult to talk about. And you need to create a nice rapport with your patient to allow a comfortable zone where there's almost no judgment when they start speaking to you about their sexual dysfunction. Most commonly, they present with low libido, erectile dysfunction. With regards to their, the vitality, they say, I feel weak all the time. I'm not able, my memory is terrible. I feel hot all the time, sweating. Infertility is very important. You want to ask that on history because it will determine the type of management you're going to give this patient. So whether they desire fertility or not, that's something you should ask on history. With regards to signs, reduced body hair, gynecomastia is very common. Remember, because also from the aromatization of testosterone to estrogen in adipose tissue, they'll have a surge in testosterone and estrogen that can lead to gynecomastia. And then another main presenting sign is your anemia. All right. So for the history, what I would also do is when the patient comes in, I'll take a good past medical history. I want to know about comorbidities. We know that there's an association between comorbidities and hypogonadism. So diabetes, hypertension, thyroid issues. Surgically, have you had orchidopexy before, previous undescended testicle? Did you have a torsion? These kind of things are very important to ask. Neurological history, you're looking for pituitary lesions, so you want to get a history of headaches, visual disturbances, any anabolic steroid use as a younger, teenager or, at any point in their life, actually. Recent illness, so an acute illness, just the flu alone, we spoke about COVID already, but just the flu alone can be enough to just knock off your access temporarily. So recent illness with a low testosterone that's been in front of you could dignify. This is why we ask you to repeat the blood test for a second occasion to confirm it. Fertility issues or concerns, as I said, with regards to fertility, remember, we're living in a different world. Just because your patient is 55 doesn't mean he's not dating a 25-year-old. So don't assume that because he's 55, he's not interested in procreating or wanting to start a family with that individual. I'm not condoning that behavior. I mean, if you're 55, I'm not going to judge if you have a 25-year-old partner. I'm just saying I know a really good urologist who can help out. Just let me know. With regards to questionnaires, there's a host of questionnaires that are available. The issue with the questionnaires is that it's mostly used for research, and a lot of the questions there don't specifically relate to hypogonadism, but also just relate to normal aging process. So I wouldn't use a questionnaire as part of my general history. This is just a nice table I wanted to add in. It breaks the symptoms down to sexual, physical, and psychological. The one thing I wanted to highlight was this one here that said difficulty walking greater than 1 kilometer. I was like, and most people can't walk 1 kilometer. I don't think that's going to relate to hypogonadism, but just a nice structure in that slide. This was a gentleman, Will Rogers. He was famous, a long time ago, like in 30s and 40s, right? He was famous for being a cowboy in American movies, but his actual fame came from his witty sense of humor. So he says there's 3 kinds of men in this world: the one that learns by reading, the one that learns by observation, and the one that learns by having to pee on an electric fence. Now, the point of the slide is that I want you to do the second one. I want you to observe. When a patient walks into your room, the key thing or the best thing you can do is to observe. Remember, these men are not going to talk to you. They're not going to tell you about their problems. They're very shy. Some of them are so used to the symptoms, they think that's how life is. So the key thing I want you to do is observe the patient as they walk in. Look at his BMI, look at his fat distribution, look for potential gynecomastia, look at his general mood and his outlook. Just, signs that could point you towards a particular direction. As I said, a lot of these patients, they come into our clinic with real problems. Hypogonadism is something that gets missed very easily. Okay, and then general examination, key things I'd focus on and picking up would be a jaundice, just to look for liver cirrhosis, anemia, and edema. Edema because cardiac failure may be significant in terms of treating these patients. We'll get onto that later. Urogenital exam is absolutely vital. You must check the testicles for volume, symmetry, the presence or absence of testicles. Sometimes it's a nubbin because he had a torsion 20 years ago and it didn't really realize. It's just like, I've always had a small testicle, or sometimes bilateral. It makes a significant difference in terms of how we're going to treat this patient. Penile size and length can also be done. A digital rectal exam is absolutely, absolutely vital. The reason why is that picking up potential prostate cancer will be a contraindication to treating this patient with testosterone therapy. So a PSA and a digital rectal exam is an absolute must. So testosterone, unfortunately, well, maybe fortunately as well, doesn't always stay at one level throughout the whole day. It has what we call a circadian variation, where basically at certain parts of the day it's high, certain parts of the day it's low. And the way this generally works is that from midnight, it starts to go up. This is, in my opinion, evolutionary. This is when, as the testosterone starts to peak, this is when, how do I say, all the action happens at night. So what happens is the testosterone starts to peak slowly. It reaches a peak around between 8 to 11 a.m. and then starts to drop. So much so that if you had to do a testosterone between 8 and 11 a.m. and then after that between 11 and 4 p.m., you'll see a 25% difference. Obviously, a lot higher here and a lot lower here. Sometimes you get referred a patient has a testosterone level maybe of 6, 7.5, but you see it was done at 2 o'clock in the afternoon. Repeat it the next day or repeat it early in the morning and you say, oh, this PSA testosterone is 14. No need to treat this patient. So it's of vital importance that all our testosterone testing be done between 8 and 11 a.m. This must be done in a fasting state, because food can also affect your testosterone levels. Look, that's a bit controversial at the moment. There's some evidence to suggest that fasting doesn't really make a difference. But the way I look at it is that if I'm doing a testosterone level in this patient, I also want to know for comorbidities, I'm going to do a fasting lipogram. So it makes sense for me to be doing a fasting test on this patient. Okay, back to our quiz. So another MCQ for everyone. I'd request you again to just come back onto the chat and give your answers. So you can diagnose a patient with low testosterone based on how they feel. So options are A, true, B, false, C, I feel like sitting on the fence today, D, no thanks, I'd rather stand. So I made that a little bit easy. So I'm getting some A's, I'm getting a lot of A's. I'm getting one B. Got a C. I like that guy. The person wants to sit on the fence. It's a good fence. A lot of A's. A resounding amount of A's, eh? Which is impressive. Thank you so much, everyone. Thank you so much. The truth is you can't, eh? Because remember, a lot of these patients don't tell you how they feel. And a lot of them are so used to how they feel that they think it's normal, so they don't even mention it to you. So not to say that symptoms aren't important. They are absolutely important. If they're positive and they tell you, yes, you can assume a diagnosis, but you have to do a blood test to confirm this. I would be reluctant to start a patient on testosterone therapy on clinical symptomatology alone due to the potential risk of adverse effects from testosterone therapy. Remember, it is a drug and it potentially can be a lethal drug. So we don't want to just give it out unless we're dignified. So I would definitely make sure before I assume that I have a blood test, which moves on to our investigations. So we spoke about it. Normal test that we'll do will be testosterone level. Ideally, you want it above 12. The free testosterone can also be done. Sex hormone binding globulin can also be performed. And these tests are usually done with a variety of assays. Now, these assays are based on your lab and what you have available at your center. Now, there's two main methods of measuring total testosterone are your immunoassays and your liquid chromatography tandem mass spectrometry. That's a mouthful, so we're going to call it LCMS going forward. So your LCMS is your gold standard. The reason why is because if you look, again, another statistical, maybe at some point we'll have a talk on statistics just to help you interpret these papers. It's a very complicated area of medicine because I know for some reason us clinicians are not very great at statistics, but once you have a grip on them, it's a wonderful topic. So the coefficient variation basically tells you how likely is it that this test, if done in different times, will be different. And so the coefficient variation for LCMS is a lot lower than immunoassays. Basically, doing a blood test today and doing one tomorrow can have up to a 15% variation, which is not good for someone who's about to be put onto hormone therapy. With regards to measuring free testosterone, equilibrium dialysis, by far the best test with very minimal coefficient variation of 7%. So these two would be your gold standards. They are expensive, so obviously it depends what you have in your center. But what advice I can give you is that whatever test you employ, stick to it. Whatever lab you employ, stick to it, because each lab has a different assay, and you don't want to be doing it from one lab and then having a result from the other lab, and it's difficult to assess response to treatment as well. So we spoke about testosterone, free testosterone, FSH, LH, vital to differentiate primary from secondary hypogonadism. Prolactin, definitely, I would definitely do a prolactin level if ever the patient has a low libido, sexual drive, or if I'm suspecting secondary hypogonadism, or if they have other features such as galactorrhea, or neurological symptoms, I would definitely do a prolactin level. Estradiol, it's great to have a baseline level. The reason why is because now when you start giving this patient testosterone therapy, and if ever they are on, if they are obese or have a higher, adipose prevalence, they will likely aromatize. So you want to monitor that estradiol level to a reasonable level because estradiol in itself, in excess, can also cause complications. With regards to imaging, MRI, gold standard, especially if there's biomarkers, the biomarker suggests secondary hypogonadism, or if they have neurological symptoms or elevated prolactin levels. So when will you not give testosterone therapy? Patients who have untreated breast cancer, definitely a no-no because of the potential for testosterone being aromatized to estrogen. Estrogen is a precursor or promoter of breast cancer, so definitely not. Prostate cancer as well, absolute contraindication. Patients with desired fertility, remember, we give testosterone, we basically are replacing the testicle. The testosterone goes to the brain and says, hey, hold up, I've got enough. Stop making GnRH, stop making FSH-LH, and you switch off the gonadal axis. Now, on short-term use, it is possible and theoretically reversible to restart that axis. That being said, I have seen patients, and I'm talking about young patients who go to gym, obviously competitively want to get better muscle bulk, taken testosterone therapy for 2 or 3 years, and now coming back with flat testosterone levels for the past year and a half, 2 years. One of them actually desired fertility, came to ask me what we can do to help them get fertile. And to be honest, there's not much we can offer them. There is some evidence that over many years, they may regain function. But in all likelihood, you will tell your patient, listen, if I do give you testosterone therapy, you are likely not going to be fertile in the future. That should be known, and be very clear about it and have no shame when telling the patient this, because should you not, that can come back and medico-legally be binding to you. So make the effort, speak to the patient. There's no rush in doing any of this until the patient is aware of all the potential risks that are possible. So another thing is the hematocrit. Hematocrit above 54% is the absolute contraindication. The issue with that is that it increases the viscosity of blood and increases the risk of venous thromboembolic disease. Another thing you want to also screen the patient for is sleep apnea, because that can also increase the hematocrit. So just keep that in mind. Poorly controlled congestive heart failure as well, very high risk. Do not give them testosterone therapy. Patients with LUTS, lower urinary tract symptoms, that's my field now. Patients with the IPSS score above 19. So an IPSS score is the score of to assess difficulty in voiding, with a lot of parameters that are present that basically assess the severity of their bladder outlet obstruction from their prostate. So what happens is testosterone increases, it's converted to DHT. DHT increases the volume of the prostate. If you increase the volume of the prostate, you increase the bladder outlet obstruction, make the urinary symptoms much worse. But the reason why that's not in red is because it's a relative contraindication, and the same for thromboembolic disease. A nice way to remember it, look, you know what? You're going to go back to your clinics. You're not going to remember this slide, but you might be able to remember this. So something I used when I was trying to remember this when I was writing exams was cheap breadsticks. So each letter, CHEAP, is one of the contraindications. So congestive heart failure is for the C, the H is hematocrit, the EAP is pretty much all relating to the prostate cancer. The B is for breast cancer, the S for sleep apnea, and the other S at the back of the stick is for LUTS. So just a nice quick way to remember it when you're seeing a patient in your clinic. So the European Association of Urology has these guidelines, and I'll put this in just to highlight a point that don't use testosterone therapy in patients who are eugonadal, who basically have a normal testosterone. Even if they have symptoms of decreased vitality or feeling weak, if they have a normal testosterone, you can further investigate by checking that their free testosterone is normal. Maybe they have a high serum SHBG. But if it's completely normal, do not give them testosterone therapy, as they may have negative outcomes to it. Patients with mild erectile dysfunction and who are hypogonadal will benefit from testosterone therapy. There's strong evidence for that, so that's great. Patients with severe erectile dysfunction. So at our masterclass, we're going to talk about erectile dysfunction in detail. We'll talk about how to differentiate mild, moderate, and severe forms of erectile dysfunction. We'll talk about the pathophys, the anatomy. It's a wonderful topic. So we'll talk about the long and short of erectile dysfunction. So the idea, if patients have a more severe form of erectile dysfunction, is to use a combination of PDE5 and testosterone. Patients with depressive moods and osteoporosis, you use conventional therapies. So basically give them the calcium. You can give them drugs for their moods. Don't use testosterone therapy to reduce weight or enhance metabolic status. And don't use testosterone to improve vitality and physical strength. So I think this highlighting that when we should not be abusing testosterone for non-significant indications. So how do we treat it? First thing we always say, lifestyle modification. And I think this is always important and must be stressed to the patient. There's no point throwing drugs at them. Look, I understand sometimes they're not going to make a difference. I do acknowledge that. And practically speaking, from experience, patients don't lose weight. They don't eat better diets. They don't exercise. And the hell is not going to stop drinking and smoking. I guarantee that. That's true. But out of 100, maybe 5 will. And I think it's important to target those 5. So the meta-analysis documented that a low-calorie diet with exercise can significantly increase your testosterone levels. So there is merit in it. But that being said, exercise alone will only increase your testosterone by 1 or 2 nanomoles. So for someone who's sitting at testosterone of 11, 12, which is fine, then you're going to improve them. But someone who's sitting at 6 or 5, it's not going to make an impact. So in those situations, I recommend giving both combination of pharmacological and lifestyle modifications as a combined approach, and the results are better for those patients. So what are options for late onset hypogonadism? So we can give them gonadotrophins. We can give them testosterone preparations such as either oral or parenteral. We have transdermal options, which are great, patches and gels, less invasive, and transmucosal, even less invasive, which is your buccal and nasal sprays. We'll talk about that now shortly. So bear with me. This slide is a lot of information. I don't want you to take anything from it. Just have a look at it. These are the gonadotropins. So basically, these are replacing your FSH and LH from a central level. So this is great for your secondary hypogonadism. You don't need to remember the doses or any of this. You just need to know that this is what we use for our secondary hypogonadism. For our primary hypogonadism, so when you have testicular failure itself, these are the testosterones that are available that we can use. I'm just going to highlight the most important ones. So with regards to the oral, it's wonderful, it's convenient. People can, they don't have to worry about injections. But the issue is that the oral preparations are very unpredictable in terms of absorption. You have to take it with a fatty meal. Sometimes you have to take it 2 or 3 times a day. Just to get patients to remember to take it 2 or 3 times a day is difficult, but then to make them have a particular type of meal in our population that who don't regularly have the luxury of choosing their meals will be a bit hard. It has a lot of GI side effects, and also it can increase your blood pressure significantly. Now, remember, you're already treating a population who has hypertension. Increasing the blood pressure further may not be the best idea. So another potential risk of oral testosterone preparations, that is a risk of hepatocellular carcinoma, and that's because of the first pass metabolism. So it generally is not something that I would use personally. The parental, I think for more people than not, I think that's the mainstay of treatment, the injectables. Testosterone enanthanate is the most commonly used. It's fairly cheap. It's short acting, so if there's an adverse effect, we can withdraw it quite quickly. Issue with this is that there's very high fluctuations in circulating testosterone levels. So you get a big peak, patient feels great. 5 days later, he's like, oh, I feel bad again, doctor. I feel very weak. I feel tired. And there is a relatively high risk of polycythemia. By and large, if our patients can afford it, testosterone undecanoate in castor oil. Now, I know when I say castor oil, it's bringing back a lot of flashbacks to some of your grandparents who gave you this when you were sick. It was a big mess, but I promise you this is just going to stay in the injection. This castor oil helps keep the testosterone, sustained for a longer half-life within the body. So you only have to give it every maybe 3 months, which is great compared to these other ones, which they do say 2 to 3 weeks, but to be honest, by the second week, they're already at the trough and they're feeling it. So testosterone undecanoate in castor oil, in my opinion, one of the better ones. That being said, it costs 2,400 Rand a dose, right? Bear in mind that dose is going to last you 3 months compared to what you're going to pay, say, 200 Rand over every 2 weeks. But the fact that you only have to do 1 injection is quite helpful. What are the issues with it? Very painful. And I'm saying painful, I mean very painful. I've given this injection, the patient didn't like me. I tried. It's just very painful. The reason why is because it's actually an oil solution. So literally it takes like 2 minutes to inject this into the buttock. You aim for the gluteus medius. And other issues that you can have with them is that there is a risk of anaphylaxis with this preparation, and there's also a risk of oily pulmonary microemboli from the oil itself. That's fairly self-limiting, and if ever that does happen. So what they recommend is that The patient stays at the practice for a bit. You observe them. Should they have any difficulty breathing, you just do supportive care, oxygen, and just observe them, and they generally improve on that. But it's just important that if you do give this injection, keep them in your rooms to monitor for anaphylaxis and for the risk of pulmonary oily microembolisms. Okay, so surgical implants. Look, that's wonderful because it's almost like how, you put the implant, it stays there, it doesn't bother the patient, he doesn't have to take a tablet, he doesn't have to get an injection. However, the issue with the implants is that it's invasive and there's a risk of extrusion and infection. Now, my concern is that if you have a lot of these patients have comorbidities. If a patient's already immunocompromised in terms of diabetes or HIV, do I want to be putting a foreign body into a patient like that who may have a risk of further infection? Probably not, in my opinion. Transdermal patches, amazing, because that's least invasive. You just put a gel or a patch, and you get wonderful steady state release of testosterone. Now, the disadvantage here is something I want to highlight. If there's anything you take away from this presentation, take this. There is always potential for transfer of that testosterone to people around you. So if you have kids, or if your patient has kids, specifically younger children, less than prepubertal, you need to be very cautious because that testosterone can, be transferred onto them, and they may undergo precocious puberty. Now, that can be a medical legal nightmare. So you need to speak to the patient, counsel the patient. It's like, okay, sir, tell me about your surroundings. Do you have family around you? Do you have kids around you? Okay, this is the potential risk. I don't recommend topical therapy because of that reason. Because it is nothing worse than having a 7-year-old or 8-year-old undergo puberty when those only supposed to start happen 4 or 5 years later. So yeah, just keep that in mind whenever you're using topical or transdermal therapy for testosterone. Transmucosal, yeah, look, it sounds great, but a lot of people complain about it, of the nasal irritation or the unpleasant taste. So yeah, but again, offer it to your patient and see what makes them happy. A nice quick summary. I use a summary for myself during exam time. It's just gives you the advantages and disadvantages of each modality. What about clomiphene citrate? I know we all familiar with clomiphene citrate. We use it in gynecology obstetrics when we wanted to induce ovulation. It has a role also in the male. So basically, clomiphene citrate is a SERM. It's a selective estrogen receptor modulator. It's a method of preserving fertility in a male patient with hypogonadism or low testosterone. It acts on the pituitary, and what it does is it decreases your estradiol negative feedback. So it blocks the pituitary receptors, your pituitary estradiol receptors, so that when you do produce estrogen, it basically tells your body that, okay, wait, there's not enough estrogen, make some more. So your FSH LH increases. Your LH then acts on your Leydig cells and tells your Leydig cells, hey, hold up, make some more testosterone. And by doing that, it also acts on the Sertoli cells to make more spermatozoa. But the caveat to that is that it only works on patients with low LH levels. If you have a normal or a high LH level, clomiphene citrate is not your answer. So what you can do is that if the patient has a low LH level, you can try. If there's no response and you repeat your LH levels, if it's still low, you can increase your dose to 50 milligrams on alternate days. You repeat your bloods, still no response, but your LH is high now. That's when you know your pituitary has responded. And despite your pituitary responding, your testosterone is still low. You need to call this patient, you have to consider this patient as having testicular dysfunction, and you need to change your strategy for him. HCG, also a gonadotrophin. It's a LH agonist. Can be given in the subcut or intramuscular injection. Has a very short half-life, so it needs to be dosed more regularly. Aromatase inhibitors, specifically for a population who is on the larger side with a higher BMI, more adipose tissue, you want to inhibit that aromatization. So it blocks that process by blocking the aromatase enzyme itself. So as a urologist, what I would choose. So for me, if I have a high-risk patient with cardiovascular disease or multiple comorbidities, someone I'm concerned about obstructive sleep apnea, high hematocrit, I will cut my risk for this patient and give them a gel initially, as long as there's no contraindication to the gel. The reason why is that if he should have an adverse effect with the gel-based testosterone, I can withdraw it immediately. Remember, the gel-based testosterone requires daily dosing, whilst if I give them injectable, I'm kind of stuck with it for 3 months, so depending on the one I'm using. So I'll reserve my testosterone undecanoate and in castor oil for those low-risk patients. So, for them, they'll have the potential for having adverse reaction will be much, much lower. Just another thing I want to mention about the gel, sorry, before we go on to the next slide. It's important that when you're applying this gel, you tell the patient on the day when we follow up to check the levels that they don't apply it to the area of the antecubital fossa. Sometimes patients apply the gel in that area and then you do a blood level and you get a crazy, crazy high level in the hundreds. And then you wonder either this patient started doping with anabolic steroids or they've applied the gel in the area of the skin where the needle took the blood from. So just something to keep in mind, something practical that you just need to advise your patients. Okay, so for follow-up, these patients need meticulous follow-up. I can't stress enough the need for follow-up. So every 3 months for the first year, and in these 3 months, these are the things I want you to focus on. Just remember, before we became specialists, we were all generalists. So always do the basics. Check the blood pressure, check the sugar, check the waist circumference, BMI, very, very important. Do a clinical examination for the breasts. Do an annual digital rectal exam to assess the prostate. Recent literature and high-level evidence suggests that testosterone supplementation does not increase the risk of developing prostate cancer, but that doesn't exclude the patient who already had a predisposition to develop prostate cancer. So it's important that these patients be screened initially, preferably by a urologist, with a digital rectal exam and a PSA to make sure that we are not giving testosterone. Remember, testosterone is a driver of prostate cancer. So it would be an absolute sin and criminal to be giving a patient with this with prostate cancer testosterone. So hematocrit should be measured, your testosterone, lipid, and glycemic profile. A DEXA scan is great as a baseline because we want to see the change in bone mineral density. So it doesn't have to be repeated annually, maybe after 2 years again, but it is something to assess the patient's bone mineral density. So the final decision of what you do is based on your patient. So it should be based on the clinical situation. It should be based on what your center has available. I mean, it's nice to show you these beautiful testosterones when you only have one option available. So, but in the perfect world where everything is available, I think your patient should have a bearing as to what they prefer the most. Cost is a significant determining factor as well. As I said, the testosterone decanoate in castor oil costs 2,400 Rand. So whatever we do, we should just bear in mind, even though it might be for the best for the patient, I don't want my patient putting his whole pension onto one injection when he doesn't have enough money for his basic livelihood. And then I think it's also important to assess the patient's needs and expectations. If the patient needs to play with his grandchildren, I'm not going to give him a topical steroid, testosterone-based. It's just take out that risk factor away from them. As I said, the consequences of such would be detrimental. So what about testosterone therapy in cardiovascular disease? Look, this is a very topical area that was contended for a very, very long time. So there's no randomized control trials that have proved a clear answer on whether testosterone therapy affects cardiovascular outcomes. There actually is evidence to suggest that it might be beneficial in preventing, major adverse cardiovascular events. But what I can tell you is that it's definitely contraindicated in patients with CCF. And if you have a patient with a recent MI or significant cardiovascular disease, rather get an expert opinion prior to initiation of testosterone, because the last thing you want to do is try treating someone's hypogondism and then they end up having an MI or go into cardiac failure. Okay, MCQ time again. So which of the following is true about opioid abuse? The prevalence of opioid abuse has been decreasing in the recent years. B, the opioid use stimulates the hypothalamic pituitary gonadal axis. C, short-term use of morphine can cause testosterone levels to drop. D, chronic opioid use diminishes testosterone production by action on the hypothalamic pituitary gonadal axis. Or E, none of the above. If I can request you again just to jump on the chats, please, and then just select an answer. And then, yeah, I have a nice point to make from this slide? I'm seeing some C's, D's, and E's. Lots of D's. I think you guys like the letter D. I promise you, I did not make the right answer D's in all my MCQs. This is just happening by chance. So the right answer is D. Thank you, everyone, for answering.
It
The
is.
right answer is D. So, yeah, look, the reason I put this in is that because I don't think many it's on a regular daily basis. I can't tell you. So in our clinic, we see, let's say, up to 80 patients a day. We have 2 clinics a week. Out of those 80 patients, at least maybe 20, 25, 30 of them will ask you for tramadol. Doctor, I need some tramadol for my pain. And, I'm very reluctant to give tramadol. I'm the Panado kind of a guy. And despite that, they will still insist, no, nothing is better for my pain. But what I'm actually doing by giving that opioid or tramadol is actually inducing hypogonadism. So there was a study that basically showed that long-term opioid use are linked to hypogonadism and access. So it's just something to keep in mind. The next time you decide to prescribe the opioid, just think twice of before. I've always, when I was in training, I was always told that Sanjay, nobody dies from pain. They die from what we give them for the pain. That don't get me wrong. I'm not saying don't treat patients with pain. Of course, please do. You must comfort patients as much as you can in terms of giving them analgesia.
Okay, colleagues, are you able to hear me? All right. I think we lost Dr. Sanjay. He'll be back.
Sorry about that, Isago. I think I had some my network decided to give out. Let me just start sharing again.
Okay.
Could I just request if you could just let me know where I got cut off? Okay, just confirming. Can you hear me now?
Yes, I can. We can hear you loud and clear. Yeah, I think you're on this slide. Yes.
Oh, lovely. Okay, sorry about that, everyone. Just a bit of network issue. So yeah, as I was saying, so basically long-term opioid use has its complications, and we end up, treating the patient for pain, and then we end up causing another problem, whether it be dependence or tolerance to narcotics, or the fact that we are actually inducing iatrogenic hypogonadism. Just something to keep in mind. Don't get me wrong. If you have a patient who's, terminal cancer or is, in severe pain where it's absolutely affecting their way of life, please, by all means, don't let them suffer. Give them what they need for analgesia. It's just that sometimes, if ever you're feeling a patient just being addicted to a particular drug, then you can consider withdrawing it or just giving them other analgesia. Okay, this was actually the last, well, I felt we'll do a bit more quiz. It's nice to consolidate. So I feel when I study, I do better if I test myself after a topic. That way it helps me consolidate the information and then, basically help me prepare for an exam or a clinical scenario. So if everyone doesn't mind, we can just ask a few questions. It won't be too long. And they're fairly good, interesting questions. So again, chats are open. I'll allow you to read these questions, or if you prefer, I'm happy to read them as well. But okay, so with regards to testosterone replacement therapy, testosterone replacement should not be recommended in the following situations: A, B, C, or D, or E.
Even me, I know this one.
Damn it. I made a mistake. I should have made the right answer D. I don't know why I left it in. Oh,
Yeah,
that's really that's wonderful. Either that was a very easy question or I'm a very good teacher. But yes, well done, everyone. The answer is E. So every single one of those are important. So patients with fertility, you need to be considerate of giving testosterone therapy in them. Patients with breast cancer, all are basically contraindications to giving testosterone therapy. So well done, well done. Okay, next one. Which of the following statements is false? Reduction in circulating testosterone levels occur as part of normal aging. Testosterone supplementation is available in formulations for oral, intranasal, transdermal, sublingual, or transnasal. Clinical data suggests that a modest impact of testosterone supplementation on physical functioning. Globally, testosterone prescribing has been decreasing over the years, over the past decade, and large placebo trials following patients over decades are needed to establish safety and benefits of testosterone supplementation. So let's see what everyone feels on this one. Again, I promise. I genuinely did not hear. Like, this is so good. Yeah, 100%, eh? So actually, globally, testosterone prescribing has been increasing over the past decade. That's in light of the fact that our average life expectancy has increased, so more patients experience hypogonadism, and also the fact there's more awareness, social media awareness. I mean, if you look at most of the Hollywood actors that are out there right now, they look good, eh? I mean, compared to a 50-year-old man, 30 years ago to a 50-year-old man now, it's a huge difference, and a large proportion of that is because testosterone is being employed in the right situations for the right indications. Okay, well done. And then, all right, next one. So which of the following statements about androgens and the prostate are correct? Testosterone is a primary androgen affecting prostate cells, prostate growth. Higher circulating serum levels of androgens increase the risk of developing prostate cancer. Men with hypogonadism will never develop prostate cancer. Exposure to androgens before or at puberty are necessary for development of prostate cancer. And type 1 alpha reductase is the enzyme primarily responsible for converting testosterone to DHT. So let's see what everyone says.
This time the answers are coming in slow.
Yeah,
Yes, 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 colleagues.
yeah, wonderful. So yeah, you're right. The right answer is D. Exposure to androgens before or at puberty are necessary for the development of prostate cancer. So yeah, just to address, like, testosterone isn't only the primary androgen affecting prostate cell growth, it's actually DHT. So androgens itself doesn't really increase risk of developing prostate cancer. So men with hypogonadism can still develop prostate cancer. The reason for this is that they use non-testosterone-based pathways to develop cancer. So that's why in some situations, in a small subset of patients, you can have a normal PSA with prostate cancer. A patient with like a very low PSA can still develop prostate cancer. So just something to keep in mind. And then, okay, I think this is the last one if I'm not mistaken. The efficacy of testosterone therapy is best judged by A, the restored diurnal pattern of hormone levels, B, normal reference range serum testosterone level, C, mid-range serum testosterone levels, D, normal score using hypogonadism questionnaires, or E, hypogonadism symptomatic improvement. So I'm going to give you a hint there. I was quite averse to the questionnaires, if you remember correctly, so keep away from D. Wonderful. Yeah, 100% guys. Well done. You guys are doing really, really well. So most of you answered E, and that I agree with that. Hypogonadism symptomatic improvement should be your goal. Great. I end with this slide, and I just want to highlight the key factors that we need to be considerate of when treating a patient with testosterone deficiency. I think it's important to speak to your patient about their fertility needs. As we said, old, young, doesn't matter. Speak to them. You'll be surprised, eh? You'll be absolutely surprised at how I've seen 75, I've seen crazy numbers that I don't understand, because I'm not sure who's going to take care of the kids afterwards, but they want children. The potential for thromboembolic disease. Find out if they have a family history of previous thromboembolisms or previously had a PE or a DVT. Measure the hematocrit. If the hematocrit is raised, consider doing a sleep apnea questionnaire. These things are wonderful. They give you the chances of patient having sleep apnea, and thereafter you can do a actual invasive, not invasive, but a nocturnal sleep apnea test, and that could be responsible for the raised hematocrit itself. Patients with cardiovascular disease, especially uncontrolled or grade 3 or 4 cardiac failure, should not be receiving testosterone therapy. Polycythemia, again, back to the sleep apnea topic. The risk of transference, very, very, very important. So when using a topical testosterone, please counsel the patient the risk of potentially transferring this to their partner or the kids around the house. Tell your patient the symptoms may not improve. So just because you're giving them testosterone does not necessarily mean that they're going to feel that vitality everyone speaks of. It's important also to help keep their expectations in check. And all patients must be screened for either BPH or prostate cancer. And that's it. Thank you so much, everyone. Hope you enjoyed that.
Thank you, thank you, thank you, thank you, Sanjay, Dr. Swadini. Yeah,
Thank you.
very, very, very empowering. I think all the colleagues who are still here will attest to that. And it is quite a very important topic, I believe. And for a change, we are talking men's health. And yeah, very, very empowering. I mean, I had my 20 questions as always. But on a lighter note, as you say, Bota, you didn't talk about tight jeans. Do tight jeans impact on hypogonadism?
I don't say that. I love my skinny jeans. Yeah, I love my skinny jeans.
Uh,
No, actually, you know what? I think tight jeans are more related to varicocele because what
okay.
happens is tight jeans increases the temperature of the testicle, and you get
Yeah,
varicosity, dilatation of blood vessels, and
yeah.
then that in itself can lead to impaired fertility, but not necessarily hypogonadism. It doesn't affect the endocrine function; it affects the spermatogenesis. Yeah.
Okay, super, super. It was on a lighter note. And I see Ryan says, thank you, Dr. Swadini. Lovely talk so far.
Thank you,
Testosterone is
Ryan.
one that drives us nuts. Ryan, Ryan, Ryan.
I love nuts. I love it.
So yeah, thanks, Ryan, for that. Anonymous says, I had a 14-year-old male patient, tenor stage 1, with an empty scrotum. Can I confidently say that it's hypogonadism?
Yeah, no,
Hmm.
that's very nice, Anonymous. You look, I think hypogonadism is more. Remember, we spoke about the four categories in order to
Hmm.
diagnose hypogonadism. So we need to have clinical symptoms, and we need to
Hmm.
have done it early morning, fasted, and there needs to be a low testosterone level associated with that. But what I think that patient actually has is an undescended testicle. So an
Hmm.
empty scrotum, and it's also important to clarify whether it's unilateral or bilateral. But if
Hmm.
it's bilateral and that testicle has never descended, you often
Hmm.
get a hypoplastic scrotum. The scrotum it's almost not present. It's flat. There's no bulk in it. That means the testicle never came down. And because it's sitting so high up, it's not able to perform its endocrine function adequately.
Hmm.
So I think the important thing for that patient would be to go to a urologist, investigate for that testicle. He may need an orchidopexy, whether being open or laparoscopic. We need to find the testicle. And what's important in this particular case is that it needs to be done soon because there is a risk of malignancy on a testicle that hasn't descended. So we need to
Hmm.
get this done fairly soonish. Ideally, if a testicle hasn't descended by 18 months of life, we do it before 24 months because
Hmm.
after that period, the endocrine function and the potential for fertility gets affected.
Hmm. Super, super, super. Freddy is asking probably a straight question. Can a person with one testicle present with low testosterone?
Yeah, no,
Low
like Freddie, and actually not really. Hey, a lot of our patients have one testicle, either congenitally or from a torsion or some trauma. What
Mm,
happens is that God's been kind. He created two. So when one goes away or disappears, the other regains the function. It's kind of
mm,
like we also see this in kidneys. a patient who's born with one kidney,
Mm,
the one remaining kidney actually doubles in size to overtake the function of the other. Similarly,
mm,
the testicle, so the one remaining testicle will increase and be hypertrophied to accommodate and maintain a normal testosterone level. That's a very
mm.
good question.
Super. Awesome, awesome. Okay, there's questions about fertility, but also penile size. Does testosterone have an impact on the size, or even can testosterone be used to improve fertility? I think it was on the chart by Kabankele.
Yeah, no, actually, quite the contrary. Testosterone will impair your fertility because when you give testosterone, it'll create a negative feedback loop to your hypothalamus gonadal axis and
Mm,
basically tell your hypothalamus to stop and your pituitary to stop producing FSH and LH. Now, remember, FSH is what tells our Sertoli cells to make spermatozoa. So if you give testosterone, it actually cuts off that whole pathway, and you get a patient who's now infertile. So back to the point I was saying earlier with the patient, one of my patients who used to go gym a lot. He's trying to have kids now, and he's absolutely struggling. I don't know how, but his sperm analysis came back. With the sperm count, which is usually in millions, it came in as 0.5. So
yo.
I'm not sure where they found half a sperm. I'm not sure. That doesn't make any sense to me. But they found half a sperm.
Have a sperm, only the head.
I'm a bit suspicious of that laboratory technician. I'm just a
The
bit suspicious. So
That's quite interesting. I don't know if, because I don't know Ryan. You know, Ryan, sometimes you're not sure whether he's serious or it's a joke.
no,
But you know,
I'm absolutely serious. I swear, I promised you. This patient came 2 weeks ago, and his
oh,
some of the attendance here will be one of some of my registrars. He will
uh,
actually showed me the patient, and it was 0.5. And I was
zero
wondering,
0.5.
where did this guy find half a sperm? Um,
Yeah. All right. In terms of penile size or length, are there charts, ranges, or something? What is an
yes,
acceptable centimeter?
100%. Yeah, that's a very difficult question for a man to. I don't want to tell them now because they'll Google it and then they'll plot themselves. But they are normograms based on both age and sex.
Okay.
Yeah, they have normograms based on the size. So you take the age and the race and then the size, and then it gives you an idea on 10 cells and how basically how if it's normal, above normal, or below normal.
Okay.
Yeah.
Super, super. We will check that. Um, I think the issue of treatment for low testosterone levels, we have addressed. And then maybe is it safe then to treat a patient with testosterone who has BPH?
Yeah, that's Philip, that's a brilliant question.
Mm,
So look, it depends on how bad the symptoms are. So the International Prostate Symptom Score, the IPSS, is a wonderful tool to
mm.
determine the grade of severity of patients with BPH or BPE because yeah. So the issue comes in is that it's difficult. I think in these situations when there's a bit of a multitude of factors, referring a patient like this to a urologist would help because at our disposal we have a machine called a uroflow. So the uroflow is a machine where you void into, you pass urine into the machine, and it gives you a graph on how well you void. Based on that, we make the decision. If it's mild, then yes, testosterone therapy shouldn't affect the patient. However, if they're having moderate to severe LUTs, they are at risk of going into acute urinary retention and then further going at risk of obstructive uropathy and potential renal failure and urosepsis. So I'd be a bit skeptical um, to start a patient with severe symptoms or even moderate symptoms on testosterone.
Super, super. I think the issue of fertility you have addressed, but I see people are specific on the sperm count. But
Yes.
generally, your recommendation is not to use testosterone to
Definitely
improve.
no. I think it's a big
Yeah,
no-no. Okay? It will
yeah,
actually, as much as it'll be counterproductive, it will diminish, kind of similar to my patient with zero point 0.5. That's exactly what will happen. They will be azoospermic because it will knock off the hypothalamic pituitary axis, and the brain won't be able to tell the testicle to make more spermatozoa because it'll think there's enough. Yeah.
yeah. Yeah, colleagues, just as I'm sharing the link for the erectile dysfunction masterclass on the chat, please do check it out if you are interested, Mervin, because I'm looking at your question. But maybe to rephrase the question, Sanjay, it's a question of how does HIV impact on male hypogonadism, HIV. I think with COVID and other things, we got a sense of what's, is it the
Yeah.
drugs or the HIV infection itself?
Yeah, look, we spoke about the three components of testosterone. So
Mm,
the hormone binding globulin proportion of testosterone increases in
mm,
HIV. Now think of
okay.
that as the useless testosterone, the uncontributing testosterone. That's the testosterone that sits at home and does nothing. So
Mm,
in the HIV population or in the aging population or in liver cirrhosis, that proportion increases and it actually decreases the amount of bioavailable free testosterone to act on your body. So put it this way, patients with HIV who have a higher SHBG have a less functioning type of testosterone. Um, and that's why
mm.
HIV is a significant factor in this disease.
Superb, superb. Sibuti is asking a female. I'm not sure, Sibuti, but anyway, she says a 35-year-old female with low libido. I think he means it. I'm hoping it's a male, but you'll Sanjay. But a 35-year-old, because the question talks about a 35-year-old female with low libido. Do we give Viagra or testosterone? Uh,
I think Djibouti might have meant, I hope, well, it could be either. Hey,
yeah.
I don't think it's wrong. It could be a female. Um,
Okay.
I yeah, I think that's a difficult question because I need more information. So in order to yeah, you see, in order to determine whether I'm not sure of the role of giving testosterone to a female. The reason why is that the doses formulated for testosterone supplementation is indicated for a male. I'm not
Mm,
sure if ever there's evidence to supplement females with testosterone. The reason why is because they're going to have um, masculinizing features. I'm sure a
mm,
35-year-old female won't appreciate the fact that she starts developing facial hair and a deeper voice and sees a decrease in the volume of her breasts. So that's the offset of giving testosterone to a female. Um, However, testosterone is vital for a female in terms of libido. So I'm because I think Subhuti mentioned Viagra as well. I'm assuming this is because of low sexual desire.
mm.
In that case, that patient needs a full workup as to assess why is she having a low testosterone? Is it
Mm,
because she has something going on from the brain that's increasing production, favoring production of estrogen? Or is there an issue with the adrenal gland that also produces sex hormones? So
mm,
I would not condone giving these doses of testosterone to a female. I think a better and more suitable person to ask would be a obstetrician or gynecologist, because they would be better in that, in that specialty. I
mm,
unfortunately can just tell you what I'm happy to give men with low libido testosterone.
Sanjay, do you sometimes see women?
Oh, yeah, yeah. A lot of our patients are, I think about 30% of our patients are female. And yeah, no, we see female on a regular basis in urology.
As the primary patient or as a secondary patient?
Oh no, as a primary patient, hey, so there's a whole.
Okay.
But I'll tell you something. I'll tell you something. So we'll talk about
Yeah,
this in the erectile dysfunction masterclass. A lot of these
yeah.
patients come into the rooms with sexual dysfunction, erectile dysfunction, quite
Mm,
angry at each other. You can see the tension between the husband and wife. And
yeah.
then you see them 3 months later after I've given them medication and sorted them out and pharmacologically. And believe it or not, they're holding hands. And
Okay.
it's a very satisfying feeling. It is. And so it's just to highlight that, these situations, as I said in the beginning, hypogonadism
Yeah,
isn't really a male problem. It's also a female problem because it affects the partner as well. So it's
yeah.
important to keep that in mind.
Okay. Hey, Anonymous says, does warm water cause hypogonadism? You want us to have a cold shower all the time. But Sanjay?
Uh, no, I please bath with warm water. I wouldn't want you getting hypothermic in winter. So please bath with hot water. I think,
Uh,
yeah. Oh, there's no evidence for that. Sorry.
No, yeah. Okay. Is there any symptom on hypersensitive? Yeah, anonymous. You need to rewrite your question. Okay, maybe the question is about in terms of treatment, any herbs or natural, yeah, supplements and stuff that are known to, I don't know, work. I don't know if there's science to confirm or not. It's usually a
Yeah,
great, yeah.
yeah. I see ashwagandha there. People love using ashwagandha for everything. Hey, I've seen that everywhere. I've seen that in soap as well. I don't know what they, but yeah,
Yeah.
look, I think that's a very good question because there are a lot of supplements out there that, number one, are not governed by anybody. No
Mm,
medical body that governs them. So it is highly possible that testosterone is present in these supplements, but bear in
mm,
mind they're oral supplements, so they will have the side effects of taking oral testosterone. Another issue with that is that even supplements that do contain testosterone may not contain testosterone to the dose you need it to in order
mm,
to have a clinical significant impact on your health. So I do not warrant or condone any use of supplements, particularly in this situation, because it's hard to, number one, regulate those drugs to see if they genuinely are pharmaceutically graded. And number
mm,
two, it's hard to monitor these patients because each tablet may have a variable amount of testosterone in it. So
mm.
to monitor these patients in terms of potential toxicity will be very difficult.
Super, super. All right, the two last questions. Anonymous says, so the patient had bilateral undescended testes. What confused me was the absence of pubic hair. So now confirmed one testis is in the left inguinal region. Um, I don't know if it's a follow-up from that first
Oh, that's
patient.
wonderful. Yeah.
Yeah.
Thanks for replying, Anonymous. What you have there is bilateral undescended testes. And what I'd also like to know is that if ever you examine the penis, was there a hypospadias present? So the reason I ask was that if you have a combination of hypospadias and an undescended gonad, you need to consider that this patient may have a disorder of sexual development. So a disorder of sexual development means that there may be a chromosomal discordance to the phenotype. So
Mhm.
basically, as if this patient should be referred to a urologist. So you're welcome to refer to your closest urologist. But this patient does warrant further investigation on multiple levels. Firstly, for the bilateral undescended testes, the fact
Mm,
that I mean he's 14, he should be undergoing puberty at this point, and if he has no pubic hair, he has endocrine dysfunction. So we need to start considering getting him to endocrine as well to see whether he may benefit from hormone supplementation. Um,
mm,
just a proviso to that is that often, just with my experience with our endocrine team at my hospital, is that they're reluctant to give um, testosterone because it does cause premature closure of the growth plates. So, like this patient is someone who definitely, if you can track this patient down and get them to a urologist, that would definitely be the best case scenario for him because we need to do a basic chromosomal analysis on him. Um, I know you said you palpated the one gonad in the inguinal area. That's not to say that that gonad is definitely a testes. It could be a over testes because the over testes can also descend. Um,
mm,
so there's a lot going on. Very interesting case, but
mm.
we need to just do a little bit more investigation, a bit more work on it.
Super, super. Sibuli talks about a previously undescended testis, which is now, I presume, descended. So he's asking, how do you evaluate its functioning? Is it the same evaluation with the hormones, or there's other things we need to look at?
Yeah, you see, it's very difficult to evaluate a testes after surgically correcting it into its rightful place. The
Mm,
reason for that is because any hematological test you do, you won't be able to isolate if it's from that testicle or from the contralateral one that's overtaken function. You know what I'm saying? So
mm,
what I would do in a testicle that was undescended, I'd clinically assess it. If the volume is good and it hasn't atrophied, and if you compare it to the other side, and if it's the equal volume, I would assume that testicle is functioning. We don't often routinely assess function after orchidopexy. Number one, because it's very difficult to do it. I'm not aware of any way you can, you can find the function of that testicle. But generally speaking, if the volume is good, it's equal size, and morphologically, if it's normal, then it's working. Bear in mind that after puberty, or after 18 months, spermatogenesis is always affected. 18 to 24
Mm.
months. So after 24 months, spermatogenesis is affected. But the contralateral testicle should take over that function. And in terms of fertility rates, it's lower, but paternity rates, the ability to become a father, it's equal with one testicle. Yeah.
Okay. Okay, we are 4 minutes before the internal medicine. So maybe Claudia, I think, has resubmitted. Would a testicle show or have any physical symptoms such as hypersensitivity to touch? We need a little bit of background. Are you referring to when you use testosterone or yeah, but I don't know. Is that 1953, Sanjay? I don't know if you're able to,
Yeah, I can see that. I also don't understand the question.
yeah,
Sorry.
the
Would
context.
SC
Yeah,
show physical symptoms such as hypersensitivity to touch?
yeah,
Sorry,
yeah,
I'm not. Maybe if ever Claudia could just,
yeah.
re,
All
yeah.
right.
Uh,
Yeah.
yeah.
So maybe
Sorry.
we leave it at that. Claudia, please do send a detailed or the context of your question to info@clinicalcareplatform.com. And then we can relook at the question and try to respond to you. But colleagues, just to appreciate you for taking time to be here with us this evening. In another world, it's just me and Sanjay talking about this topic. It really becomes very great because you are here. So we really want to appreciate you. Sanjay, as we close, do you have any closing remarks? And then we call it a night. Thank you.
Oh, thank you so much. I just want to reiterate, please, yeah, Claudia, feel free to send that email across. I'm happy to answer any question that you have. And to everyone as well, thank you so much for attending. Thank you, Ryan, and thank you, Seiko, so much. I enjoyed this talk. It was very nice. I hope everyone enjoyed it as much as I did.
No, we did. I've just crossed 240. So it means there's a lot of exercise and lifestyle modification. And then I shall visit your practice, Dr. Sodani, so that
Oh, 100%.
we can
Wonderful.
assess if I need some injection. Colleagues, I know I'm not the only one. Let's go and have a queue there.
Anytime. Absolutely. Anytime.
Okay, colleagues. Thank you very much. May the good Lord richly bless you. Bye.
Bye. Thank you.